Good afternoon, everybody, and I welcome you all. With me, I have my partner in crime, Sneha. So together, we will be taking you forward with a few small nitty-gritties of Pentacam and how we can learn together on Pentacam. I do not have any financial interest, and I take liberty to announce that Sneha also doesn't have any financial interest. Am I right, Sneha?
Yes.
Okay, perfect, great. The question arises, why a cataract surgeon needs to have a topographer? That's the question which we first ask. Like, is it mandatory to have a topographer? We all now know that topography is an integral part of cataract and refractive setup. Now, let me take you through a case where you have a person who has come for a toric IOL. On IOL master, it shows that there is a cylindrical power of 1.4 diopter. Patient underwent toric IOL, and post-operatively patient had cylinder of 3 diopter. Now, where was this cylinder hiding behind? Well, interestingly, when we did Pentacam, this is what the cornea looks like. So basically what was happening here was the cornea had asymmetric astigmatism, and because the topography can pick up this asymmetry, whereas our humble keratometer just measures the meridians and averages out. And that's the reason why we missed out on that irregularity there, and we put a toric IOL and ended up with a problem there. So we know that Pentacam is useful for regular astigmatism, which are with the roll, against the roll, or oblique, or anything. But anything which is irregular, well, we know that toric IOL may not be the best case scenario. So when we look at using toric IOLs or multifocal IOLs, the topographers are must, and we do not have alternative to that. When we have topography machine, the first thing arises that, like, how do we interpret topography? Well, I really don't think we need to go into detail of how to interpret topography, but simple thing like Placidus-based topographer has a regular nomenclature which is followed everywhere. The warmer color is steeper cornea, cooler color is flatter cornea, as simple as that. Interestingly, Rabinowitz and colleagues, they published an article where they showed that there are usually 10 shapes which are possible on Placidus-based topographer, of which the refractive surgeon and cataract surgeon, we are worried about the last shape, which is asymmetric bent bow tie pattern, which is the pattern of keratoconus. So remember, when we see such kind of thing, that's where we possibly should be concerned about. The question arises that yes, we are talking about topography. I'm convinced that yes, we need topography. But why do we need tomographers? Well, let me take you through another case where you have an interesting person here who has come with a report where he was posted for LASIK somewhere else. And he carried printout of topography, Placidus-based topography, and they had measured ultrasound pachymetry of the cornea, which central pachymetry was 500. The topography based on Placidus topography look fine, and if you look at what we discussed, possible 10 shapes, the shape what we see here is with the rule astigmatism or a vertical bow tie shape. So can we go ahead with LASIK? Interestingly, when we did a Pentacam here, what we see here that the thinnest pachy is not thinnest in the center part, it's much away. So when you did ultrasound pachymetry in this case, you actually didn't hit the thinnest point. Interestingly, the posterior surface showed elevation, and this was certainly not a great case for laser refractive surgery. Thus, we do need tomographer which help us study the back surface of the cornea, where we can possibly look at what's hiding behind and not just the front surface. Now, when we have Pentacam, as Dr. Narayan was saying, that we have the machine, but how do we capture the scan? There are certain nitty-gritties of capturing Pentacam scan. Can we have somebody where we can, Sneha, can you help us show somebody how to take a scan? This is Akash. Akash is a fellow here, and he's been extremely useful in coordinating all these things, especially for the Pentacam. Thanks, Akash, for all your help.
Now, coming to how to acquire the scan. First, we go and enter the data of the patient. Once the data is entered, then we go and click load the data, and then we go and click on scan. Once this has been clicked, the patient is made to sit comfortably on a chair in front of the machine. The chin should be ideally placed on the chin rest, and the forehead should touch the headrest. Make sure that there is a black mark that is present in between the chin rest and the headrest is along the along the level of the eye. Tell the patient to look into the target in the machine. In the machine, it's a red target. Once we are starting the capture, make sure that you look from the side. Make sure that the blue light coming from the slit of the Pentacam illuminates the entire cornea. There should be no head tilt, head turn, or head turn.
Well, one interesting thing here we should follow is tell patient what to expect inside. So if patient sits there and they do not know where exactly to focus, it possibly can lead to confusion and they may start chasing the light. So always tell them that there is a blue light, streak of light which rotates. Center of the blue light there is a red light, and in center of that there is a fixation point. That's where you're going to see. When we are acquiring scan, it's very fast. It takes a second or two to acquire the scan. But please encourage them by giving inputs like, please don't blink, keep your eyes open and touch your forehead and don't move, kind of thing. Positive inputs to patient does help you to get a better quality scan.
So the head tilt is very, 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 very important. So do not, that is the first thing which you have to make sure that the scan's done. And like the point which Dr. Himanshu said is, don't keep telling the patients not to blink while you're trying to get it ready. So it's very important, tell him to just close his eyes while you set and keep everything ready, position his head, keep everything ready, and when you're just about to start taking the scan, then you tell him to open. So he's not tired, you know, or else actually you only would have induced some amount of dry eyes before you actually take the scan. Yeah, please.
So interestingly, our subject seems to have undergone some laser refractive surgery. Okay, quite nice.
What about the light condition when we're taking the Pentacam?
That's an excellent point.
That's a very important point which we have to stress. Are you checking mesopic conditions, or that should be highlighted?
In fact, we had taken one video of such kind of thing. I don't know whether resolution allows us to share the video. Akash had made a video that, as Dr. Tityal said, the way Pentacam works is that it throws a light, a blue color light, which scatters less, hence the blue color light, a slit of the light in the center of the cornea. And because the entire rest of the cornea is not illuminated, it's not visible there. But if you keep the ambient light on, the cornea in front and behind would actually be visible. So that's not the best thing, and hence, as Dr. Tityal said, it's very important to keep the ambient light dark. And
this is a very, very important point which Sir said, because every machine is different. See, now let's say if you're doing a contour treatment, right? When you're doing the registration of that patient, it's reverse. You have to have an extra torchlight focused on the pupil, and then you register. So there is more chances of you having successful registration on the bed when you're actually doing the treatment. So this is a small tip. So every machine is different. So anyway, we'll be discussing. And Dr. Ron, please.
How dark does it have to be? How dark does it have to be? Are you talking pitch black or
I really
light?
don't think so. Even if there is a light, you still would be able to acquire the scan. It's absolutely fine. It's not as bad as we think. But when the ambient illumination in the room is on the lower side, it does not illuminate the cornea. Hence, earlier we used to be provided with a cloth, black color cloth, we cover on the face of the patient, so you don't need to switch off the light, that's fine. But I don't find it very aesthetically pleasing to cover somebody's head with that, and so we reduce the illumination.
Generally, even in our diagnostics, we make sure that there's no windows at all in our diagnostic room. It's completely with AC, and the lights are always dim, just on the floor, so that people can, walk to their places concerned. So that's what we do, sir. Yeah.
I think we oh, you got it? Okay. Okay, ठीक है, चलो, no problem. We can come to the video next. Now, the question arises, now once you've done the scan, now that comes in your hand, and this is where many times we sort of feel little concerned that how do I read the scan? If a new person goes through the machine, the very simple thing, I'm not going to take you in detail of any theory, just remember elevation based topographers usually can have two types of pattern, either island pattern or saddle pattern. Saddle pattern is typical pattern of astigmatism, right? So elevation based topography, two pattern. Let's see the scan. Now this is a scan where this is 4 map scan. The first one which you are seeing there is the curvature map, which is very similar to what we saw in Placido. So possible 10 types of shapes which we see there, we discussed earlier. Then comes next, which is the anterior elevation. We discussed that anterior elevation, any elevation map can have two types of elevation, either island pattern or saddle pattern. What do we have here? Looks like it's a saddle pattern. Okay, next below, which is posterior elevation. Again, elevation based topography, two types of pattern possible, island or saddle pattern. What do we have here? Looks like it's a saddle pattern. And then finally we have pachymetry map, which is intuitive, where we see the corneal thickness. Looking at all these things, it looks like it's with the rule astigmatism. Bravo, you know now how to read a pentacam, as simple as this thing. Now, let's give you another example. Now, let's see this case. We go one by one. We first look at the data, we look at the K values, you look at the quality score. It's very important to make sure that the quality score is good. It's white color, it's not yellow or red color. Otherwise, that means there is some issue with the quality of scan. You look at the curvature values and those things, and then you go to the scan, which we saw that those eggshell scan. Well, again, 10 possible pattern. What pattern do we have here? Looks like it's asymmetric astigmatism pattern or asymmetric bow tie pattern, which is usually seen in keratoconus. Let's go to the anterior elevation. Again, two types of pattern possible, island or saddle. What do we have? Looks like we have an island, and the center of the island seems to be a little bit steep, or rather taller. Hence, there is a mountain in the center. So, looks like there is an elevation there. Let's go to the posterior elevation map. Again, elevation based topographer, two types of pattern possible, island or saddle. What do we have? We have an island pattern, but the center of the island, there seems to be a red color. There's a mountain there in the center. So if you think about it, everything is fitting into keratoconus. So what do we have? We have a case of keratoconus. So it's as simple as this thing. Go map by map, and it should be actually absolutely fine. The question arises, there are so many other elevation based topographer. Why do I like Pentacam? I like Pentacam for many other things. There are a lot of other things which Pentacam does. Let me take you through another case. Somebody who has come here with a history of myopia which is stable and seeking LASIK, no other significant history other than PCOD. The 4 map of Pentacam seems to be fine and nothing much to be worried about, and possibly the question arises, can we go ahead with LASIK? Interestingly, Pentacam also shows something else here, and that's something which is called Bellin-Ambrosio Enhanced Ectasia Display. Bearing the long name, what it means is we remove some part of the central corneal data and then refit the elevation based curve there, and then look at how if there is any enhancement of ectasia there. Looking at this thing, the first top part, what you see here is the front elevation on the left side, then the back elevation on the right side. The middle map is the exclusion map, where you are removing the central area of that circle, dark circle which you are seeing, and then fitting the curve, and then looking at it. And the bottom map is the difference map, and which tells you that there possibly can be an abnormality here. Looking at such kind of thing, we know that these cases are possibly cases where we should not be looking at weakening the cornea, and maybe a phakic IOL can be better. And that's the reason, one of the reasons I would rather say I like Pentacam. Dr. Narayan was talking about the calibration, and every machine needs to be calibrated. In fact, most of the machines, they come with the calibration tool, and we regularly calibrate them. Pentacam, however, does come with tool which usually is not shared with the user. It's been done by the company, so we do not need to. But please remember, as Dr. Narayan was telling you, that unless we see the raw data, unless we walk to the machine and we find out if everything is okay, we may end up in trouble. So let me take you through one example here. One case I had where the patient had come in, like the middle map is 2015 map, right? And the later map, 2022 map, and the same person, same eye, and there's significant change in the curvature here. The question arises, does patient have some ectasia or something else happening to the patient? Interestingly, I have a habit of walking to my machine and looking at the raw data. When I went to my machine and looked at the Schimflug image, the second time, as you can see here, the bottom map, this is the first time where the edge detection is fine, the curve is fitting nicely, but in 2022, there was a problem with the machine, and as you can see here, the machine was not detecting the curvature of the cornea properly, and that's the reason why the corneal curvature was wrong there. Unless I walk to my machine and see this scan, I would have possibly treated this patient or not treated the patient if somebody was suitable for some refractive surgery.
And the whole point is, this is something that all of us don't do. This is the whole point of having this session is, this is something we just look at those maps and then we take a decision and be done with it. Actually, we don't go back and see if the scan was done properly or did the acquisition or the machine, did it really recognize the edges properly. So it's very important to have a look. So please make a note about this particular thing. It's very, very, very important. Yeah, please.
So does it mean Pentacam is foolproof? No, I think Naren just touched upon that part, that you just can't trust every possible thing on every machine. Let me give you one more example. Now, this is a person who had undergone cross-linking for keratoconus, and 10-month post-op, patient was okay. You can see the asymmetric bent bow tie pattern of keratoconus. After that, 14th month post-op, there is suddenly increase in the curvature. Now, that means there is a progression. Well, we had done cross-linking and now still patient is progressing, which is not a good sign, which is not a good thing to me. Interestingly, when we repeated the scan after 17 months, it regressed. It became again like how it was at 10-month follow-up. Now that means it's regressing. Now what's exactly happening? If it was stable and then it progressed and then again it regressed, it looks like it's an unstable cornea. What's happening here? Interestingly, when we look at the scan done on 14th month, same time, same day, 2 minutes apart, and look at the difference what you are seeing. The same day scan has a huge amount of difference, and that's exactly what we talk about, which is called test-retest variability. You should be aware that every machine can have variability or test-retest variability. There are enough data published about variability of every machine, every parameters. All you need to do is just go through, read about it, and just, if your difference, whatever you are seeing, lies within your test-retest variability, you may be fine. But if that's more than 2 standard deviation away from that, there is something wrong going on there, right? So on the same day, make sure we take 3 scans. I always insist that you should have an odd number scan. So make sure you have 3 scans and always look at all 3 scans. The example for that is one more gentleman here. Now this person had come for a routine checkup. And look at the scan, which is done 3 minutes apart, same eye, same day. The amount of difference is mind-boggling, right? By chance alone, you would have got a printout of the first scan, and you would have different interpretation. By chance alone, you would have printout of the second scan, and you may have different interpretation. That's exactly the reason why you should, if you have the machine, have a habit of walking down to the machine or at least sensitize your technician who can go through all the scan and make sure there is no variability there, right? And that's the important part when we look at such kind of thing. So what do we learn with such kind of thing? Always do more than one scan. I prefer 3 scan, and when in doubt, please repeat. Let me take you through one more interesting thing here. Now, this is again a cross-linking. What you're seeing is a difference map. On the left side is a curvature map. On the right side, it's elevation map. This is pre-op minus post-op. So last map, what you are seeing, the first map, what you're seeing is the last visit. The middle map, what you're seeing is before surgery, and then it's the difference map, right? So you can see that there is a significant amount of flattening which we could achieve after cross-linking, right? That means, well, it's working. There is a regression there, and we are very happy. The interesting part starts here. When we see the posterior surface, there is actually increase in the posterior elevation, and there is reduction in corneal thickness. That means the keratoconus is progressing. That means it's failed. Then what exactly we are dealing with? Front surface tells me that it's really nice. You've done a good job. The back surface tells me, you know what, that's really bad. You're in deep trouble. Well, the interesting part is Pentacam shows you something else which is called densitometry. You can go and see on the machine. This is the pre-op densitometry because there was nothing else there. And post-operatively, when we did cross-linking, there was a haze there. Whenever there is a haze, the machine finds difficult to do an edge detection. And hence, there can be fallacious result based on the level of the haze. If the haze is little posterior, even your posterior elevation may be abnormal. When posterior elevation is abnormal, your pachymetry will be abnormal. The haze is in front, even your anterior elevation and curvature map will be abnormal. So typically, cross-link patient immediate post-op, or rather initially couple of months, can have significant haze. Be aware of that and do not jump over with an inference that whether it's not working or something. So what do we learn here? That elevation-based topographer, especially post-cross-linking, may not be very reliable, and just take the data with a pinch of salt here. Now, one more case we are seeing here. So if we go by the maps what we discussed, looks like there is a significant curvature which we are seeing on the curvature map. There is anterior elevation, posterior elevation, looks like ectasia, right? Maybe keratoconus. Otherwise was, mind you, totally normal. Well, possibly if we look at the belly and ambrosio display, those values, everything below, all red color, very bad. So looks like possibly very bad ectasia what we have here. Can we have this case displayed on the machine? So by default, it looks like ectasia. And we are seeing here that there is a significant elevation. But can we have, along with this thing, a Scheinflug image? Yes, that's a Scheinflug image. And if you can see here, well, there is actually a scar there. And what scar has done? Scar has flattened the cornea there. The problem is not about ectasia. Problem is scar has flattened the cornea. Next to the scar, there is a relative steepening. What we are seeing is not actually the ectasia. We are seeing the effect of flattening of the scar just above that. Now, can we go back to the 4 map, please? Now, interestingly, if you look at the thinnest pachy, Sneha, can you show me the thinnest area of pachy down there? That's not correlating with the curvature map or elevation map, nothing. So thinnest pachy is not in that area. Interestingly, as we discussed earlier, your Pentacam will not be reliable when there is a scar like this kind of thing. So always see a patient on slit lamp first. Always, whenever there is a scar, go and check the data, whether the data is reliable or not. Sneha, can you show me? Okay, I'll show you here. I'll show you. So Pentacam also does something called corneal densitometry in the on-fast mode or in front mode. You can see the scar. this is how the scar looks like. And this is how such bad scar is. Because of the scar, what you have is a fallacious keratoconus, which is not keratoconus, right? So opacities on the cornea can actually lead to pseudoectasia, and this you only will be able to notice if you go and see the data. If you look at the printout, well, possibly you would have cross-linked this patient.
And this happens a lot where, I mean, we are not supposed to do, but a lot of time, you know, a friend of a friend sends reports on WhatsApp with all these scans, and obviously you just look at it and you just label something, which actually you might go wrong. That is why we say, you know, we should always see the patient. You know, things can be completely different, and this is a very good point, which shows the importance of actually seeing. And clinically, you need to correlate your findings, what you see in your slit lamp, on your devices, everything, and then come with a final picture or the treatment for it.
Although the Pentacam is a wonderful machine, I think you should not rely on one machine in these cases and combine the findings with what you see on your anterior segment OCT, because that gives you some additional information, especially in these cases. Yeah.
True, very true, very true. So we go to next case. Now, this was a very interesting case. One very kind gentleman who happened to be one of the war hero and our Air Marshal, Mr. Mittal knows him, walked in and he was to undergo cataract surgery. They were looking at multifocal IOL or something. So finally, they did the Pentacam. And what you're seeing here is in this display, the first part what you are seeing here is on different date, which is 6/9/23. On the second part, what you are seeing here is 5/9/23, right? The first one is the axial topographer. The second one, bottom line, is tangential topographer. So forget about that, but just remember, on that day when he came, this was how his cornea look. There is a significant isolated flattening in the center of the cornea. And of course, I was not happy. One thing, you can't put a multifocal IOL, you can't put a toric IOL in such kind of cornea. But interestingly, if you look at the shape, this is not a shape of most of the disease. His cornea was normal, clear, nothing much out there. This is not somebody who would have done LASIK also. I called him back next day. He used to come to the hospital for nearby hospital for his other issue, medical issue, came next day, and that central flattening disappeared. What exactly was happening there? Well, interestingly, somebody had done an ultrasound A scan there, contact method, and had touched the cornea in the center part. And this was the warpage of the cornea, which you are seeing with an A scan, which is unnecessarily pressed on the cornea. Unfortunately, I didn't have an idea that day somebody had touched his cornea. Otherwise, I possibly would have interpreted it that day only. The interesting part here is that whenever you have a system in your hospital or your clinic, make sure that one, of course, we would not want to do a contact A scan. We would always wish to do an immersion A scan. And second, whenever they are doing any other optical scan, that has to be done before you touch the cornea, right? So whatever tomographer or topographer you're using, if you're not careful about such kind of thing, you may end up having some issues like this thing.
And usually this happens in a teaching institute. Even though you have created a system, one enthusiastic new PG or fellow looks like the high IOP. He just simply does the GAT without telling you, and then goes for the rest of the workup, and you're just looking at the scans and then interpreting. So it's very important to just keep all these things in the back of your mind. Things can be different than what the story can be a little different than what actually the scan is showing. Please.
So one more such kind of case. Now this case has come for cataract surgery. Refractive surgery, LASIK. The refraction is okay. Has a cylindrical power. It's a compound myopic astigmatism. But if you look at the scan, the curvature map on the anterior surface looks pretty bad. There is significant asymmetry, significant curvature high. Does not look very nice. So That's something which we should keep in mind. However, the back surface is absolutely fine. Pachymetry is pretty okay. I'm quite okay with that. The other eye also is less severe, but almost similar picture in the other eye. What exactly we are dealing with? Anterior surface, there is an asymmetry, maybe keratoconus, God knows what. Posterior surface, no change. So can it be anterior keratoconus? Well, interestingly, we know that there is nothing like anterior keratoconus, right? If cornea becomes ectatic, both the surface go together. In fact, posterior surface will go more than the anterior surface. So what are we dealing with? Well, if the cornea is weak, well, we checked his corneal biomechanics and everything was normal. So cornea is not weak cornea, mind you. So it's not a weak cornea. What we are dealing with here is contact lens warpage. This patient is a contact lens wearer, I told you earlier, has toric contact lens because there's significant high cylindrical power, and that's the reason why you saw the changes which are occurring on the front surface of the cornea. The warpage which occurs with the contact lens can be at the epithelial level or anterior stromal level, but it does not affect the posterior corneal curvature. So whenever you have somebody who is wearing contact lens, it's very interesting and very important to ask them the history about the contact lens and what kind of contact lens they are using. Make sure you stop the contact lens. If that's a toric lens, you should be stopping it for a couple of weeks' time at least and repeat the scan. If you're still in doubt, stop it further and repeat the scan. When in doubt, repeat the scan and wait it out. If it's a soft...
And this protocol, actually what all of us we tend to do is we do it after the patient comes to the hospital. Actually, the protocol should be the person who receives the call, the receptionist or the, the person who actually takes the appointment for the patient there itself. If the question should be, are you coming for any other specific this one? Are you wearing contact lens? Okay, please, be off contact lens for a week and then come with all your reports. At that point only, if you tell the patient, you'll save a lot of time because patient comes, you tell them to go back, then again come again. So it's a very not a very healthy experience. So that is something that we have to do. Dr. Ron?
How long to stop soft lenses and hard lenses?
So if we look at the data, there is something which is published which shows that there are different lenses can have a different time period for generally we do feel that a soft lens which is non-toric, a week is good enough. Toric lens, couple of weeks is important. And if there are hard lenses like RGP or anything, I would wait for a month or 3 weeks at least.
Your patients are more patient than mine. Yeah. You tell them they're dependent on their contacts. Don't wear it for a week. They're already glad at me.
Yeah.
A month.
So what I do is I show them this picture and I tell them, are you looking for the lifetime treatment or you're looking for the short term? They usually select the lifetime treatment part option. So yeah.
And whenever we say that, we want, when we tell the patients that, see, I want to do the best treatment for your eyes, and by waiting for a month or a week or so, it'll make a significant difference how accurate the scans will be, then at least the patients will be more. So, but the whole point is, absolutely, like you said, if the patient is sitting in front of you and then we tell, wait for a month, they usually don't end up coming back. So the whole, if you give the responsibility to the person who receives the call for the appointment, if it's done, so they feel like, okay, I didn't wait much, before I came to the doctor, everything was ready and it was a very smooth sailing from then onwards.
So one more interesting part here. So this is a case of Fuchs endothelial dystrophy. Many times, me being cornea surgeon, I get to these Fuchs cases. Remember one thing, Fuchs endothelial dystrophy, when it's advanced, when you can diagnose them on slit lamp, by then the endothelium is already fried up. Then you do specular microscopy, you're just going to see moon surface, black surface, and it's very difficult to follow up a case like this thing. But what I prefer to do is, I like to do their Pentacam. Pentacam gives me a baseline corneal thickness all across the cornea, which I serially follow and I know there. I also know the ratio between center and peripheral corneal thickness. When it gets altered, as you can see here, you can see the percentage thickness map or PTI map here. This is not following the normal curve, it's going flat. That means the corneal thickness in center, usually which is less than the periphery, is actually matching up with the periphery and it's increasing the corneal thickness, which is typically of a decompensating cornea. Hence, when you have a decompensating cornea, the test which I love to do is Pentacam, not just specular microscopy. Now, if you see here, this is a case where we had given this patient Ripasudil. Now, you can see her. Sneha, do you have it on the machine? Can we show them on the, okay, fine. So, you can show me Pacimap, that's good enough for compare two scans. Can you show compare maps, compare, examine, display, compare two exams? Compare two exams, below, yeah, compare two exams, yeah, perfect. And can you give me the pachymetry instead of eggshell? First one, corneal thickness. You can see the difference here. So the first map, which is 2017, and the second map, which is 2018, after starting the patient on Ripasudil, there was significant reduction in corneal thickness. Right. Now, this is one of the evidence which you can rely upon that there is something working or something is not working. If it's not working, it's going to show you. Or if a Fuchs case is deteriorating, you will be able to pick up here where you will see in the difference map. So in Fuchs case, it's very, very important that you should use your Pentacam pachymetry. Final part, when we look at the phakic IOL, is there any role of Pentacam in phakic IOL?
May I add something about the Fuchs cases?
Please.
Yeah. I think that it's very important for the audience that the criteria that have been described by Patel for Fuchs endothelial dystrophy, especially in the earlier cases where you don't see changes in the slit lamp, can be very helpful. And that's
very true.
Displacement of the isopax, flattening of the posterior part of the cornea. So that's something that you can have a look at. Yeah.
So Dr. Rudy said something where Dr. Patel's Guru Sanjay Patel has worked a lot on the corneal endothelium. And being with Bilbon, I mean, he inherited that legacy of corneal endothelium study. So Sanjay Patel's group published something which was published on OrbScan, where what I was talking about, center to peripheral ratio, and how the change in the map looks like, especially on the display it looks like. It's very interesting article. We'll see if we can fetch it and share it with you guys. But similarly on the Pentacam, you can see the change in the curvature on that PTI map, which shows you the trend, and which is very similar to what they have published. But as Dr. Rudy said, it's very, very important to know about such kind of thing where you have center to peripheral ratio. Finally, when we talk about phakic IOL, is there any role of Pentacam in phakic IOL? Well, of course, we know that Pentacam is going to show you the anterior chamber depth, not only in the center, but it will also show you the iris topography, whether it's a convex iris or whether it's a flat iris or whether it's a concave iris. It's very important because what normally we trust or believe is one value of central anterior chamber depth. But Pentacam can actually give you a background story of what exactly lies in the entire eye, not just center cornea. It also helps you to measure white to white, horizontal white to white. We know the default or ideal method or most accepted method is digital caliper, but I always prefer to use two different instruments where I possibly compare with. Sneha, is there any way we can show them how we measure the white to white? So what we do is, if you can see here, she has put a scan which is 17 number scan, which is horizontal. So we are looking at the horizontal cornea. This is the Scheimpflug image here, and can we invert the image? So what I like to do is I like to invert the image, which increases the contrast. And now putting the caliper here and going on the other side, we have the measurement here. Looks like this person has a small corneal diameter, 10.7 millimeter. Very interestingly, right? So if you go by default setting of the machine, what 4map gives you, that's en face imaging, and which is not extremely accurate. So if you want to use your Pentacam for measuring the corneal diameter, I would seriously suggest try out digital caliper on the Pentacam, go on the machine and do measurement yourself, right? And don't just trust that one reading which Pentacam machine gives you. Also, we can measure the vault, though with the invent of ASOCT, the vaulting is better measured with the OCT and not the Pentacam, but it surely can be used. To summarize, corneal topography is mandatory for any premium IOL, storic or multifocal. The newer generation of elevation-based topographer like Pentacam can certainly help you to image the back surface of the cornea, which can tell you a lot of other stories which are hidden. It also helps you to detect early ectasia to rule out in cases of refractive surgery. And along with the other frills which it has, I like that machine a lot. Thank you very much. Sneha, you want to tell us something about this machine, how we can use this machine for IOL power calculation in those abnormal cornea?
Yeah.
While she's setting up, Himanshu, could I just ask you a very basic question?
Yes.
For the Barrett toric calculator, there's the integrated K calculator in which we input 3 sets of K data, and often do use the Pentacam SIM case as one of my 3 sets. Is that appropriate? I mean, given that the IOL master case are different and auto K, which is the other side, are different. And what's your comment on that? What should we be using?
That's really nice question, and that's really nice. What I would suggest is that when we do cataract surgery, we all optimize our result based on one particular instrument. So if my spherical outcomes are optimized based on my IOL master, there are chances that if I take different K value from another machine, I might miss out something there. Having said that, if somebody has optimized their outcome based on K values, SIM K values from Pentacam, it's absolutely fine. So suddenly for one particular case, if I change my K values which I borrow from another machine, I don't feel very comfortable about that.
So the whole point, I think what Dr. Ron was mentioning was, see, we have, I mean, most of us do have at least, not just one, we have at least 2 or 3, or, we have many. And we're looking at the scans, all K values are different, and the axis is different. I mean, not very significantly different, but there is some amount of difference between the 3. And you really don't know which one to choose for a toric IOL. And that's when the integrated K is very, very useful. You just put these values into that, and it gives an appropriate value, and that you can feed it into the data, and then you get much more accurate toric values. So that's a wonderful tool which all of us definitely can use. I think it's been published also. It's been working fantastic. Yeah, absolutely.
Okay. Now, coming on to the role of Pentacam in IOL power calculation before cataract surgery, let's go on to the first case scenario. Here, the patient came to us, was keen on cataract surgery. The refractive foam map gives us the SIM K1 or the simulated K1 and K2 values. For this patient, it showed a cylindrical power of 1.7 diopters. Makes this patient suitable for a toric IOL calculation. These simulated K1, K2 values are values from the central part of the cornea, 3.2 mm centered on the corneal apex. These values can directly be entered into the online available toric calculators to give us the correct model and the axis wherein we can implant them, which will help us in reducing the preoperative corneal astigmatism. Now going on to the second patient. This patient had come to us and was keen on implantation of a multifocal IOL. Now there are certain parameters which we need to check before we tell the patient yes to go ahead with a multifocal IOL. These parameters include the pupil diameter, it includes the angle kappa, then it includes the irregularity of the cornea, which we can check through the EKR values. It includes the chord mu, which is provided to us by Pentacam. And it includes the higher order aberrations, which is again given through the Zernicke analysis of the Pentacam. Now first going to the foam map. Here the foam map will give us the pupil diameter. It will also, so in Pentacam we can indirectly measure the angle kappa, which which can be seen through the x and y coordinates of the Pachy at the vertex from the pupil center. Coming on to the Bailey-Baddy map. This shows Baddy values to be perfectly normal. Now coming on to the Holiday. So, this is really important to assess the regularity of the cornea. It gives us, it takes into consideration both the anterior surface as well as the posterior surface of the cornea, and it is measured considering the true indices of the cornea. So, this equivalent K reading map, we will see the amount of cylindrical power at all the zones 1 mm, 2 mm, 3 mm, 4 and 4.5 mm. The amount of cylindrical power is within the range, the variation is within the range of 1 diopter, and also the axis in all the 4 zones is less than 10 degrees. And the second part of the EKR report is the distribution of the EKR in the actual zone, which is the selected zone of 4.5 mm. This histogram as narrow as possible and as lesser peaks as possible indicates that it is a regular cornea. Now coming on to the lower central map, which shows the EKR 65 flat K1, K2, it shows the EKR 65 mean, the global mean EKR and the highest peak EKR. Now these 3 values are extremely important. The variability in the EKR 65 mean, global mean EKR and the highest peak EKR should be less than 0.5. Now coming on to the right upper map, which is a graphical representation of mean zonal EKR versus the zone diameter shown by blue, then the mean zonal axial curvature versus the zone diameter shown by red, and the mean ring axial curvature versus the ring diameter shown by green. Now the blue graph is extremely important. A slight rise in the graph from 1 mm to the periphery is normal, indicating a positive spherical aberration of 1 to 2 diopters. Now coming on to the Zernike analysis. The Zernike analysis will tell us the RMS.
The whole point of this is, see, each one of us have different machines, right? And if you're planning for a premium IOL, what data we have to look in the, let's say if you have a Pentacam with you, along with your biometry, what data we have to look at before we actually implant the trifocal IOL or a diffractive IOL. Let's name it a little differently. So that is what she's discussing. Please go ahead.
So here the Zernike analysis will give us the RMS HOA value. This has to be less than 0.5 for the patient to be eligible for a toric multifocal IOL implantation. Now coming on to the next case is a status post LASIK patient who was keen to undergo cataract surgery. Now in patients who have been operated or for LASIK or for myopia, hyperopia or post-RK patients, the ratio of the anterior versus the posterior cornea is not normal. There is a change, and hence we cannot use the SIM-K1 or SIM-K2 values. More reliable values are the EKR65 values, which can be in, can you go to the EKR65? So these EKR values are basically the anterior anterior corneal values, and this EKR will adjust it for the change in the anterior to posterior ratio of the cornea. These values for the various zones 1 mm, 2, 3, 4 can be incorporated with the online free available ASCRS calculator and can help us in determining the correct power for those eyes. Because if we use the SIM-K1 and SIM-K2 values, it will result in compensation, either overcompensation or undercompensation of the posterior corneal surface, since the ratio of anterior versus posterior has changed and can result in wrong IL power calculation. Now coming to a case of keratoconus. So in irregular corneas, the EKR map plays an important role to determine whether we can go ahead with a toric IOL power calculation or not. So in this case, the amount of cylindrical power or the astigmatism at the various zones was the difference was less than 1 diopter, and the axis was less than 10 degrees. So this becomes an ideal case to go ahead with the toric IOL power calculation. So this is a case of keratoconus. Can you go to the EKR map? Yeah. Here you can see that the difference between 1, 2, 3, 4 and 4.5 is less than 1 diopter, and the axis is the difference in the axis is also less than 10 degrees, and hence so we can think about planning a toric IOL power implantation for this patient. Now coming on to a second case which has advanced cornea, advanced keratoconus with corneal scarring. So in this map, you can see that the amount of cylindrical power from 1 mm, 2, 3, 4 and 5, the variability is increasing from 1.6 to again jumping to 4.4, then 5.79, then 6.64 and then 7.07. And you can see the axis, it's still, the variation is not much, but the amount of variation in the cylindrical power is too high. The second thing that you can see is the histogram distribution. It's a broad histogram with the multiple peaks, and so in such case scenarios it is better to avoid a toric IOL implantation, and in case if you want to go ahead with it, it's in this we can take the take the pupil diameter. According to the pupil diameter we can take the zone, and that zone cylindrical power can be used to calculate the toric IOL and then can be implanted along the axis. So, for instance, if this axis variability was more than 10 degrees, then definitely we wouldn't have gone ahead with a toric IOL power calculation, thinking it to be because of the irregular pattern. Thank you.
Thank you, Sneha, and it was wonderful to have you all here. It's our pleasure to host you for this meeting, and if there are any other questions, comment later on.
Himanshu,
we can catch
sorry,
up. Sir, please.
Like we are discussing on how to calculate IOL power calculation, basically looking into a keratometric corneal power reading only. We all understand if you have a Pentacam, it is a very good tool for a normal cornea. It gives you absolutely good reading on a normal cornea. Whenever cornea is disrupted by surgeries, by scar, by ectatic disorders, your finding gets haywire. There you have to go through all these parameters to look into which will be the correct corneal power to be taken for your patients. It's not only for ruling out patients for multifocal or trifocal, it is also important for those cases where you can't get a good topography reading by other instrumentation. There also it is very important. If I have a patient like radial keratotomy patient, where the keratometry readings are very difficult to get with the normal instrumentation, even an optical biometer may not be able to pick you good reading. Maybe the keratometry less than 34 in those cases. There Pentacam is very helpful. So there I think you should specify how to get good power reading for those cases where you have a irregular corneal astigmatism. EKR is where you are talking about. Other important thing, this is on the cataract part. Not every cataract patient will require Pentacam readings. If you have a good biometer, it will be sufficient for most cases. There are some cases where you need to have a Pentacam reading to be taken. Especially what you talked about, Himanshu, earlier. If you have a reading, 2-3 reading done by 2-3 different instrumentation, if your axis of steeper axis changes, but they are variable. If your power is variable, then you require a help of a Pentacam like instrumentation. And other area, refractive wise, normal cases we can pick up. Ectasia we can pick up. But it is important to pick up the subclinical keratoconus picture, subclinical ectasia. That we have to learn how to pick up subclinical cases so that we don't touch those patients with refractive surgery. If you can explain the last part, that EKR again, I think public will be more aware, how to pick up, which power should you pick up in those cases like a post-radial keratotomy, post-ectasia, post-keratoconus patients for a IOL power calculation.
I just wanted to bring out one more point. See, all these machines have so much data, they're not even sharing half the things. So I just want to showcase one of the studies which we have done. So basically we have devised this particular software, okay, to look in detail the corneal diameter, okay. So, and we have put it into a graph, you can see at the bottom, so we have put it into a graph. So what we found very interesting was the shortest corneal diameter had very consistently the steepest axis, okay. Let me repeat again, the shortest diameter had the steepest axis. So how did we use this? If you can go to the next slide. So if you look at it in terms of the axis correlation, it is beautifully correlating to how the eye is. Because a lot of times, like Dr. Himanshu, Dr. Sneha was discussing, a lot of times dry eyes and other issues you have and your scan's not good, you will keep thinking, how do I do it? And so on and so forth. But actually, if you just use this software, you can get your axis perfectly. If you can go to the next slide. Pani? Yeah, the next one. So how can we use this is, one is, like I mentioned, the surface is not that great. You can get good access for your toric lenses or any other planning. And also you can use it for a comparative map. Let's say if you're using a keratoconus patient and your patient has come back, because usually these corneas are not that great, already has some dry eyes and so on and so forth. And you want to make sure that the repeatability is really good. So when you do the scan, there's a chances of a little bit of cyclotorsion in these kind of cases. If you can go to the next case, the next one, please. Yeah. So you can see here, we have the bottom of, the top one is without, we have, correcting the axis. We have just done the scan and you can see the difference map. And then below is where we have corrected about a certain degrees according to the software. And then you see it is a completely different two images. So it's very important to, get this axis perfect. So that is something that I wanted to share. I think Dr. Himanshu and Sneha, do you have anything else? Otherwise, I think we can move forward. Yeah. And always fantastic presentations.
Thank you so much,
everybody.
And if